example, the superior vena cava, and there are also some other organs. Like here, you can see that there is a thymus there, which is quite important. Also, an organ for the cardiovascular malformations, especially in terms of ventricular regulations. So, when you look at three vessel views, first of all, you have to make sure that you are looking at a proper scan, because a lot depends on your angulation of your transducer and how high you are in the chest. So basically, it was very emphasized a couple of times. The best way is to do a sweep and start from the abdomen, scan up to the three vessels view, because then you will have the overview of everything, just like pick up an image and try to interpret this. As you can see in this section, this is taken very, very high. Okay, thank you. So it's the level of the brachiocephalic vein, and this is the superior vena cava, and in this image you also can see the brachiocephalic vein and the superior vena cava right here. But this image is not wrong. You just have to know what you are looking at, because as a matter of fact, it's useful, and I showed you before that in this kind of image, we can see the origin of the right subclavian artery that sometimes is showing here. So when you want to diagnose the aberrant right subclavian artery and you are not sure if you can see something like this, certainly this is a normal subclavian artery. So now we are moving slightly downward, and take a look here. You can see just one vessel in this mediastinum. Is it wrong? Is it a kind of anomaly? No, it's just the section that we've taken. Because you are very, very high, and you are just cutting the aortic arch. You can't see the ductal arch, because the view of the ductal arch is a kind of oblique. And in order to get a proper image, you just have to move downward, and then you can see this very typical V. And you have to make sure that both the ductus arteriosus and the aortic arch are to the left of the mid-sagittal plane. That, of course, is also very nicely shown by the position of the trachea, which is here. So this is our three-vessel trachea view, as it should be. So the ductus arteriosus, aortic arch, superior vena cava, and the trachea, and the great vessels are to the left of the trachea. The superior vena cava is to the right. And now we are moving down a bit and more horizontally, and you can see this kind of view where the pulmonary trunk branches, and you can see the branches of the pulmonary trunk with the right pulmonary artery behind the aorta and the SEC. And this is, again, depending on the position of your transducer, because if you will tilt it more like an oblique plane and cut three vessels in this way, is presented here, you see three circles, and there's a pulmonary trunk, aorta, and superior vena cava, and again it's normal. It just depends on what you are doing. So it's important to standardize your views, and you have to be sure that you are interpreting a proper image, because, of course, sometimes the image that you have may be suggestive of some pathology, but it's absolutely normal. And we already could see transposition of great arteries, and there were some signs in three-vessel trachea view. In tetralogy of Fallot, you could see bigger aorta and small pulmonary trunk and pulmonary arteries, and occasionally, like here, you can just see one vessel, and the other one could be hidden. And in this case, this is the truncus arteriosus, and as you can see, also this image of the three-vessel trachea is different. Now, a couple of cases I really want to discuss with you. And this is the first case. Sorry for this computer being very, very slow. And from now on, I would like it to be a bit in interactive, so maybe someone would help me, and ask the audience if they like this view. And if they don't like this view, then what is wrong? And I give you like maybe 20 seconds, and later I will tell you everything. So take your time. So, who says it's okay? Raise your hands. Who thinks that it's fine?
Ai nghĩ là mà các con nói là bình thường, giơ lên.
No one. Who says it's wrong? Who says it's abnormal?
Ai nói ta nói là bất thường. Trả lời của em.
Yes, so it is abnormal, right? So let's see what's going on here. So this is our left side, this is our right side, and this vessel here branches to two. This is the pulmonary trunk, and this is the ductus arteriosus that's visible. It means that this is the aorta, and this is the superior vena cava. So, as you can see, part of this aorta is missing. So, it ends with this circle, and it doesn't continue. So, you suspect instantly that something is wrong with the aortic arch. And what are your options?
Aortic coarctation or interrupted.
Yes, so it could be a coarctation with very, very thin arch, because sometimes it's difficult to see, and it could be interrupted.
Interrupted
Right?
coarctation.
So sometimes it's quite difficult to differentiate if it is really interrupted, or it's just very, very tiny, and you can't see it. By the way, there is another thing here. The vessel.
Aberrant right subclavian artery.
And this shows you also what obstetricians learned, I think quite recently. They learned that they have to use color Doppler in mediastinal scans, because there were some papers suggesting that aberrant right subclavian artery is a marker of Down syndrome, which is really, it's not that true, but they started to use color Doppler on mediastinal scans, and it really helps a lot. In this case, we can take a parasagittal view or sagittal view as you prefer. Of course, it's not perfect, as I said, sometimes it's tricky and difficult. This is the ductus arteriosus that shows very nicely, and the aorta divides in two, and definitely it lacks the segment. It was truly the interrupted aortic arch. So as you are mostly obstetricians, the one feature we are looking at in cases like this is the presence or absence of the thymus, and look how close the vessels are to the anterior chest wall, so the thymus could be hypoplastic in this case. And in the heart, what's visible quite often is this ventricular septal defect, and this is very, very special. So what is special about this defect that you can see in this image when it replaced? Shunting, yeah? This is unidirectional shunting left to right, and it is quite unusual for fetal scans. So it's very suggestive of some aortic arch problems. Interrupted aortic arch, as a matter of fact, is closer to econotruncal anomalies in its development than to the aortic arch problem. So it's quite often associated with 22q11, and especially when it is so-called type B interruption between the left common carotids and left superior artery, which was the case. Okay, this is something you know already perfectly.
Aberrant.
Learn about it. Yeah, the ductus arteriosus, the aortic arch, the SDC, the trachea, and a vessel behind the trachea, which is
Aberrant
right subclavian artery. And it brings us to the next part, which is about the aortic arch and its developmental abnormalities, what I coarctation or interruption, but purely the maldevelopment of the aortic arch. So it's very complex image. I don't want to talk about it too much, but the most important thing is that initially we have a set of arches that are paired and they connect to so-called dorsal aortas. So the arch developed as a paired structure. In normal development, we can simplify that we have two aortic arches, two ducts, and in order to have a normal arch, this right arch has to be interrupted, as you can see distally, to the origin of right subclavian artery and also the right ductus arteriosus has to disappear. And as a result, we have only the left aortic arch and the brachiocephalic trunk and the left side ductus arteriosus. And this is what happens when you have aberrant right subclavian artery. So there is no right duct, and the interaction occurs here between the right common carotid and the right subclavian. As a result, you have this aberrant course of right subclavian artery. What about this in terms of counseling? Of course, I think half of people will say cariotype, half of people will say you don't have to do it unless you have some other markers of Down syndrome. But what about the life of such a person in the future? Basically, most of them are totally asymptomatic. And it was regarded a kind of variation of the aortic arch for a very, very long time. And there are only selected cases when this becomes symptomatic. And basically what we are telling to the parents is that they should remember that there is something like this. They should look at their baby in case they can see the symptoms of some dysphagia, problems with feeding. Then of course it has to be diagnosed further because it can be the cause, but we don't force the diagnosis because the problem is that people are keen on treating the anomalies they can see. And in most of the centers, the treatment is just to cut this vessel. And then it's applied by this collateral circulation, which is mostly through the vessels supplying the brain. So the circulation comes back to the vertebral artery, and in some cases what you observe is the subclavian artery steal syndrome, and this is even more severe than just existence of the aberrant vessels. So you don't have to be very keen on treating this anomaly in this way. Okay, next set of images, sides, as you can see, left and right, and any ideas? Yeah, I can hear someone. Right aortic arch. Yeah? But when you say right aortic arch, it's nice to tell something about some other vessels. So first of all, where is your ductus arteriosus? It's still on the left side, but in some cases it's the right sided ductus arteriosus present. So which condition is better?
Right.
Right, because in most of cases it will behave like a normal arch, but there is one important thing to remember, that occasionally this descending aorta shifts from the right side to the left side in the thorax, and it may cause the compression. So it's not like there is no compression. In such case, occasionally it is, but it's rare. And in cases like this, the symptoms may occur in something like 1/5 of cases. So again, it's not like it means that there is a vascular ring, but sometimes the compression on the airway or the esophagus may occur.
Nó có một câu.
And
Phải. Mà cái gì mà
What
cái
is
đợt
also
đi tiếng
quite
Ozig á.
usual
À thì tốt hơn.
for
Ít
cases like
bị chân hơn.
this, and it will
Đấy
be
thì
presented a bit later, as again the same, but with description. What is typical for the cases like this is that first the vessels show something like letter U, so some people say, you can see the U letter in the mediastinum, it means that you have right aortic arch left duct, and left subclavian artery in most of cases will be an aberrant vessel. It means that it goes from the right to the left when the ductus arteriosus closes. This is how it develops, and again, the arches are interrupted in the wrong places. This is what it looks like in the specimens, and this is the pulmonary trunk, the ductus arteriosus. This is the so-called comoras diverticulum, and this is the right arch. Why is this diverticulum emphasized here? Usually, this is where the subclavian artery originates from, and usually it's thicker than other parts of this artery. So, as a result, you have a thick part of the vessel behind the trachea and the esophagus. And this is what occasionally may cause the compression. So, when you look at the right aortic arch, check the ductus arteriosus, check the standing code if it shifts, and remember that the ductus arteriosus, when it closes, it becomes the strand of connective tissue, as a matter of fact, and it doesn't grow that much. So it may just pull this diverticulum anteriorly. So in the course of time, this patient can develop the compression later. So initially there is no